A nephrectomy is the surgical removal of one kidney. The anatomy and physiology consists of the kidney, hilum, renal cortex, renal pyramid, renal medulla, ureter, renal pelvis, major and minor calyces, and the renal capsule. The kidney forms urine and filters the blood. The functional unit of the kidney is nephron. The hilum is the entry point for blood vessels, nerves, and the ureter. The renal cortex is where the blood enters the nephron and its filters. The renal pyramid transports urine. The renal medulla is the center of the kidney. The ureter transports urine from the kidney to the bladder. The renal pelvis is where the urine is collected and sent to the ureter. The calyces funnel the urine into the ureter, and the renal capsule protects the kidney from trauma and damage. The pathophysiology for nephrectomy is when severe hydronephrosis and obstruction, a localized tumor, kidney stones with an infection, and trauma to the kidney. It also can be performed when a kidney transplant is needed. The structural pathology of the GU system is diagnosed through cystoscopic examination, CT scanning, and enhanced imagery. The patient is given general anesthesia and a local anesthetic is used. The patient is placed in the lateral position and draped beginning at the 12th rib, extending from the axilla to several inches below the iliac crest and down to the table anteriorly and posteriorly. Four-folded towels and a transverse sheet are used in the lateral position draping. The equipment needed is a hypothermia mattress, SCDs, a padded kidney rest, padded shoulder braces, suction, and an electrosurgical unit. The instruments needed are a major procedures tray, long instrument tray, kidney tray, vascular procedures tray, a gastrointestinal procedures tray, a thoracotomy tray, ligating clip pliers. The supplies needed are anti-embolytic hose, a basin set, blades numbered 10, 15, 11, and 12, suction tubing, a needle magnet, graduated pitcher, ligating clips, dissectors, vessel loops, umbilical tapes, Penrose drain, closed suction drainage unit, chest tube, closed chest drainage unit, and suprapubic catheter. The patient is placed in the lateral position with the flank over the table, brake, or kidney lift. The individual is then prepped for a flank incision, and a Foley catheter is inserted before surgery. The surgeon makes the flank incision along the 12th rib, extending to the border of the rectus muscle. If a rib must be resected, the 11th or 12th rib is first stripped of periosteum with an elevator or with osteotomes. Then the surgeon grasps the rib with a coker clamp and then uses the rib cutters to cut the rib. The incision is carried through the subcutaneous and oblique muscles with an electrosurgical unit. A self-retaining tractor is placed in the wound. The perineal fascia is identified and the perineal fat is removed. The ureter is identified and double clamped with Mayo clamps divided and ligated with size O or 2O absorbable sutures. The surgeon mobilizes the kidney pedicle by sharp and blunt dissection. To ensure the renal arteries occluded securely, the surgeon triple clamps the vessels and suture ligatures are placed through each vessel. An endovascular stapler can be used to ligate the vessels. Then the pedicle is divided. The ligatures are not cut but are left long and tagged with a small hemostat. The surgeon then removes the kidney from the wound. All the bleeding is controlled with an electrosurgical unit. The pedicle ligatures are cut and the wound is irrigated with warm saline. Before closure, the operating table is returned to a flat position to release tension on the flank tissues. A Penrose drain is placed in the kidney fossa and brought out through a separate stab wound. If a rib was removed, the periosteum may be closed separately. The incision is then closed in layers. The fascial muscle layers are closed with interrupted absorbable sutures. The skin is closed with staples. A nephrectomy is a class 3 contaminated wound because it enters the GU tract.